Hello, and welcome to Breast Cancer Rehabilitation along the Cancer Care Continuum. My name is Rohini Kumar, and I'm a physiatrist at Cooper University Hospital, and I've been working with breast cancer patients at MD Anderson Cooper and enjoying my experience with this wonderful population. I want to thank you for this opportunity to be a part of this symposium. Let's get started. I have nothing to disclose. My objectives for today is to educate us about incorporating cancer rehabilitation into the comprehensive survivorship model. Let's understand some common functional impairments that breast cancer patients may develop along their treatment trajectory, and understanding what is prehabilitation, which is optimizing the patient before surgery and utilizing rehab service lines throughout the diagnosis and each stage of breast cancer treatment. Let's start off with the question. What strategy most likely improves the adherence to a prehabilitation program? Dietary counseling, exercise program, multimodal approach, or anxiety reduction? I'll give you a moment. All right, so let's start with the definition. This is from Dr. Stubblefield, who is world-renowned in this topic. Cancer rehabilitation is a process which helps cancer survivors attain and maintain the maximal possible physical, social, psychological, and vocational functioning within the limits created by cancer and its treatments. So let's dig a little deeper into this. But first, I know that rehabilitation is typically equated with exercise. And if you just leave a patient and tell them to exercise, this might happen. So we need to make sure that we give our patients a frequency, a dose, a duration, and intensity. And as you can see on the left-hand side, there are typical impairments that patients will experience that will respond very well to a structured, individualized program with exercise. This is one study that spoke to me regarding the underutilization of rehab services in the breast cancer population. Chevelle did a study of 163 metastatic breast cancer patients and found that 92% of these patients had at least one physical impairment. In total, there was 530 impairments identified, and of those, 92% required a physical rehabilitation intervention, and 88% required PT or OT. In the end, however, only 30% of the impairments that required a physiatrist actually received the treatment, and only 21% of those patients requiring PT or OT services received treatment. So this identifies the gap in care that there are impairments that patients are suffering with, and we need to better utilize rehab service lines throughout the care continuum. Especially our survivors are increasing, and if they are suffering from any functional impairments, this is where we can be of assistance. Now let's talk about what are some of the impairments that a breast cancer patient may face. This is not an exhaustive list, but these are some common reasons that patients can get referred for rehab. Patients may develop post-mastectomy pain syndrome, intercostal brachial neuralgia, axillary web syndrome, lymphedema, chemo-induced neuropathy, aromatase-induced arthralgias, tendinitis, epicondylitis, tenosynovitis, winged scapula, adhesive capsulitis, rotator cuff tendinitis, subacromial impingement, myofascial pain syndrome, serratus or pectoralis pain, radiation fibrosis syndrome, cancer-related fatigue, sexual dysfunction, body dysmorphia, or cognitive deficits. We're going to go in depth for a few of these because I see these in clinic quite frequently. Who is on the team that helps to take care of these patients? We have physical therapy, occupational therapy, speech therapy, and I keep lymphedema therapists in a separate category because this requires a specific certification for the oncologic patient. So you want to make sure that you're sending your patients to the correct therapist based on their deficit. Now, what can a physiatrist do for you? Patients that develop these impairments would respond to some of these interventions. So for example, for aromatase inhibitor-induced arthralgias, we can do peripheral joint injections. If a patient develops a tendon issue or carpal tunnel syndrome, we can do carpal tunnel injections. For those that have tenosynovitis or decurvain stenosing tenosynovitis or trigger finger, we can do tendon injections. Ultrasound guided procedures such as tenotomies. We do EMGs to recognize and identify radiculopathy and or peripheral neuropathies. Botox injections to assist with radiation fibrosis, acupuncture for pain control, as well as anxiety and or depression. Trigger point injections or dry needling for myofascial pain. We can help assess if a patient requires a prosthetic or an orthotic. If they require an assisted device, for example, if they have balance deficits, or if they need a shower chair, if they're high risk for falling, and we want to eliminate a risk factor. We also do evaluation for functional electronic stimulation to assist with weakness patterns and or TENS units for pain control. Let's get into post-mastectomy pain syndrome, which is a very common complaint. It is an umbrella term that can include both musculoskeletal, myofascial, and or neuropathic pain. The incidence rates vary from 20 to 50%, and it's defined as a cluster of symptoms. Like I said, musculoskeletal, there can be muscular-based pain generators, there can be nerve-based pain generators, and it can occur after any of these types of interventions: mastectomy, lumpectomy, a lymph node dissection, reconstruction, chemo, or radiation. A patient may complain of at least 3 months of chest wall pain or breast pain. They may describe their pain on the neuropathic spectrum: nociceptive, allodynia, burning, tingling, deep ache, itching, hypersensitivity. They may feel restriction or tightness around the chest wall. They may have phantom breast pain or phantom nipple pain. Some potential causes for post-mastectomy pain syndrome include painful, immobile, thickened, or hardened scars that can be hypersensitive. The other cause is a transected nerve. In the axilla, it is a very nerve-rich area. It can include the intercostal brachial nerve, thoracodorsal nerve, medial and lateral pectoral nerves, and or the long thoracic nerve. So since this is a highly innervated area, axillary lymph node dissection can affect and or damage any of the above nerves, causing neuropathic pain. What are some risk factors for post-mastectomy pain syndrome? It's the location of the actual surgery. If the tumor is in the upper lateral quadrant, there is a higher risk. If the patient has axillary lymph node dissection, more so than sentinel lymph node, and also the number of lymph nodes. If it's greater than 5 lymph nodes removed, the patients are at risk. Age less than 49, and the reason is thought that there may be more aggressive treatments done at a younger age. Patients with obesity may be at a higher risk because of being in an inflamed state. Socioeconomic factors, minorities have been found to have advanced disease at the time of diagnosis. If the patient undergoes radiation, and or if they have psychological risk factors such as anxiety, depression, insomnia, or if they tend to catastrophize. One example of post-mastectomy pain syndrome is intercostal brachial neuralgia, where patients will complain of paresthesias, hyperpathia, or nerve-related in the medial upper proximal arm, in the axilla, and on the lateral chest wall. This area right here, patients will complain of nerve-related pain. The intercostal brachial nerve is the lateral cutaneous branch of the second intercostal nerve from T2, and this distribution is quite typical of the complaint area. Another nerve-related issue is scapular ringing if the long thoracic nerve is paralyzed and or damaged. Patients will not have normal scapulohumeral movement. It can cause a restriction in the range of movement. It can cause use of different muscle groups, causing myofascial pain and restrictions. Another reason for pain in this area is axillary web syndrome, also known as cording. This occurs after the axillary lymph node dissection because once the lymph node is removed, the lymphatic that is attached will sclerose or thrombose and cause a palpable cord to be created. And this can extend all the way from the axilla into the forearm. The risk increases with radiation because of scar tissue formation. And again, this causes a deficit in their range of motion. Here's an example of a cord you can see in the axilla. This thickened fibrotic, it looks like a guitar string and it feels like a guitar string when it's palpated. And what's unique in this patient is that it extends all the way into the AC fossa. This will cause pain on palpation and or restrictions in their motion, causing other aspects of myofascial pain. So how do we treat post-mastectomy pain? For scapular winging, for cording, for range of motion deficits and or weakness, physical and occupational therapy is the first line. They can also do desensitization techniques, myofascial release. If the patient requires neuropathic pain control, there are multiple agents that can be used, including gabapentin, tricyclic antidepressants or SNRIs. There's evidence to show topical also control pain. TENS units, muscle relaxants. Patients may respond well if they have tightness in the pectoralis muscle with a hydrodissection into the plane of the muscles between pec minor and major. Some patients, if they are having allodynia and hyperpathic symptoms, they can respond very well to a nerve block, especially the intercostal nerve, the pectoralis nerves, and or superficial and deep serratus anterior nerves. Another topic is breast cancer-related lymphedema. I see the most in terms of lymphedema patients. The incidence is anywhere from 5% to 50%, with an average of 21%. It is defined as chronic progressive accumulation of protein-rich fluid within the interstitium, and it's because the oncotic pressure is not strong enough for the lymphatic system to continue to transport the fluid. There's a backflow. Once there's an obstruction in the lymphatics, the one-way valves unfortunately get leaky, and then the lymphatic fluid, the heavier proteinaceous fluid, leaks out into the interstitium. There's superficial and deep lymphatics. The epiphyseal, they drain the dermis and the subcutaneous tissue. This is the most vulnerable area, and they are superficial and can get damaged easily with restrictive clothing, or if one were to have IV sticks and or blood pressure checks. So that's why these patients are told not to have that on the affected side. Patients may complain of an achy feeling or a heaviness. They may have swelling that's visible. They may feel tightness or restriction in their skin. They may observe changes in the texture of the skin. They'll notice a restricted range of motion, or that their clothing is too tight or their jewelry does not fit well. Here are the 4 stages. Subclinical or stage 0 is where there is lymphatic dysfunction, but there is no overt swelling observed. Patients may complain of a feeling of heaviness or arm fatigue. In stage 1, this is where the accumulation of fluid is visible and there's pitting edema, but this is, if you elevate the arm above the level of the heart, it does reduce. Stage 2 is irreversible. So the accumulation of fluid and there is fibrotic changes in the skin and the underlying tissue, and the patient will require compressive garments and CDT in order to mobilize the fluid. This does not reverse with just elevation alone. Stage 3 is elephantitis, which is the thickening of the skin and the swelling that persists in the fibrotic tissue. What are some risk factors for lymphedema? Axillary lymph node dissection is much greater than sentinel lymph node dissection risk. If the patient has more than 8 positive lymph nodes, if there is capsular and or dermal lymphatic invasion by the tumor, if the patient is undergoing radiation, or if they are obese, if they have undergone chemo treatment with taxane-based agents, if at any point in time they had cellulitis or a seroma, because the state of inflammation causes a fluid overload, and that can precipitate and worsen lymphedema. Also, patients with multiple surgeries, because scar tissue will also impair fluid mobilization. Mainstay of treatment is getting the patient to a certified lymphedema therapist for complete decongestive therapy. And it is a multi-pronged approach where the patient gets taught meticulous skin care, how to stay hydrated, monitor their skin for infection, making sure that they have good hygiene in their nail care without cutting or pushing back their cuticles. They will also have instruction on manual lymphatic drainage, compression bandaging in order to mobilize the fluid from distal to proximal, wearing compressive garments, and doing specific individualized treatment of exercise for each patient. Here are some examples of compression garments where we have gloves, gauntlets, and sleeve, which is on the right-hand side. If a patient requires a more specialized garment, there are Velcro systems that can help to mobilize the fluid if there is difference in girth or size in the forearm and the arm, which is not amenable to a simple sleeve. There's also different nighttime garments should a patient require. If the patient is not fit properly, this could happen where the sleeve rolls down and it causes a tourniquet effect. And if that happens, then there's worsening of lymphedema. So as you can see, that patient needs to be measured appropriately by a certified lymphedema therapist and taught how to don and doff the material properly so that there is no tourniquet effect, as you can see proximally, where she's going to have increased lymphedema. And there's no gap between the gauntlet and the sleeve, as this is also going to cause downstream lymphedema. Another main impairment that I see is chemo-induced peripheral neuropathy. The incidence is from 20% to 85%, a huge range. Approximately 30 to 40% will suffer from chemo-induced neuropathy. It happens due to the taxanes and platinum-based drugs. It can occur within the first month at around 70% of the time, 60% at 3 months, and 30% at 6 months. And the damage is to the sensory nerves more than the motor nerves. Patients will have distal, symmetric, and progressive symptoms. And in this depiction by Dr. Stubblefield, you can see how the patient loses sensitivity distally most, and there is a diminishment of sensation in the hands, in the feet, and up to the calf in a stocking glove distribution. Some patients may complain of numbness, tingling, pins and needles, a burning sensation, shooting pain, a freezing or cold sensation constantly, cramping or muscle spasms, lack of proprioception, difficulty detecting hot and cold temperatures, difficulty with fine motor coordination, and loss of balance. So if a patient suffers from fine motor deficits and or loss of balance, we know that will have a huge functional impact. What are some risk factors for developing chemo-induced neuropathy? Age greater than 55, if they have pre-existing conditions, diabetes, thyroid problems, nutritional deficiencies, these can all increase the risk of developing chemo-induced neuropathy. It's dependent on the dose intensity, the duration of the infusion, the longer duration of the cancer, poor performance status at the initiation of treatment, prior systemic or current therapies, and African-American descent. How can we treat chemo-induced neuropathy? Well, the first is prevention. Many studies have shown the use of cryotherapy, which is frozen gloves or frozen socks, worn during the infusion. This challenges the periphery. By vasoconstriction, there is less delivery of the agents to the distal-most extremities. Medication-wise, we can use duloxetine. Duloxetine was the only medication shown in the ASCO guidelines to be useful for helping with the neuropathic symptoms from chemo-induced neuropathy. However, there is a caveat. If a patient is on tamoxifen, they cannot be given duloxetine. In terms of PT and OT, that is always the mainstay because we want to help these patients with desensitization techniques, balance, coordination, and fine motor. So PT and OT are always part of the equation. If the patient cannot take duloxetine, neuropathic agents such as gabapentin, amitriptyline, or venlafaxine can be used. Topical compound creams can also be tried for symptomatic relief. The last topic I wanted to bring up is cancer-related cognitive impairment, previously known as chemo brain or chemo fog. However, we now know that hormonal treatment, endocrine treatment, radiation, and chemotherapy can all cause cancer-related cognitive impairments. The incidence is vast, from 20 to 75% of patients will experience CRCI. And the complaints may be any of the above. Disorganized thinking, difficulty concentrating, word finding difficulties, difficulty with multitasking, feeling of mental fogginess, decrease in their attention span, short-term memory problems, taking longer than usual to complete their routine tasks, or difficulty with verbal or visual memory. Just to give you some examples of what medications have been associated with these deficits, FAC has been shown to have a decline in cognitive domains of learning and memory, attention and processing speed. Tamoxifen has been shown to reduce the performance in memory, verbal fluency, difficulties with visuospatial functioning, and processing speed. The main reason I wanted to bring this up is to utilize speech therapy for cognitive rehabilitation. So exercise, a catered exercise program in addition to cognitive rehabilitation are the two mainstays for neuroplasticity. And it's important to know that speech therapy does an excellent job in assessing patients' cognitive status and creating strategies to help overcome their deficit. Let's move to prehabilitation. By Dr. Julie Silver, she came with this definition. Prehabilitation is a process on the cancer continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment, and it includes physical and psychological assessments that establish a baseline functional level, identify impairments, and provide interventions that promote physical and psychological health to reduce the incidence and/or severity of future impairments. So since we are able to predict some of the impairments that occur during the breast cancer trajectory, we want to get rehab services involved in the patient's care earlier. We want to optimize the patient preoperatively. So if a patient from the time of diagnosis is given specific instructions on an exercise routine that will help optimize their status, this is where rehab services can come into play. It is a multimodal approach, utilizing exercise, nutrition, and psychological evaluations in order to help the patient withstand the long-term or late effects of their cancer treatment. Nicole Stout prepared this wonderful paper called A Prospective Surveillance Model of Physical Rehabilitation for Women with Breast Cancer, showcasing that typically rehab services are used after the impairment is identified instead of proactively and in a preventative format. So if we were to have baseline assessments pre-op, we can identify those that are at risk for developing impairments, understanding baseline range of motion and strength, their limb volume, and if they have any restrictions in their performance. We can also identify patients that have pain or fatigue or functional deficits that may impact their ability to withstand treatment. So at each stage, pre-op, post-op, during chemo, during radiation, along the cancer survivorship spectrum, patients can be reassessed with a new baseline and a new prescription for exercise would be provided because this patient may have a unique exercise regimen while they're going through chemo, but that same exercise routine would not be what they can withstand during radiation. So this concept of checking for impairments throughout their care plan and their treatment trajectory would allow us to better identify the preventable impairments and or address the impairments so that they can get and return back to function quicker. The goal would be to use prehab to leave the patient better than when they began. So if we introduce concepts of rehab at the time of diagnosis, we will be able to optimize them, make them stronger, and better able to tolerate the next steps of their treatment. So we'll come back to this question. What strategy most likely improves the adherence to a prehabilitation program? And it is the multimodal approach, because it takes a village to help strengthen and keep patients functional. So I just wanted to conclude with prehabilitation can be introduced at the time of diagnosis, and cancer rehab can be incorporated throughout the patient's oncologic care continuum. The goal of cancer rehab is to prevent and detect early impairments that patients may develop, maintain or restore function, reduce the symptom burden, maximize the patient's independence, decrease disability, and improve their overall quality of life in this complex population. So I thank you for your time. Here are my references, and I appreciate, again, the opportunity to be here.